Hello everyone, today we'll be studying about the sialolithiasis, simply the salivary stones. It is the obstructive disorder of the salivary gland. So let's talk about the etiology first. The etiologic factors favoring the sialolith formation may be classified into two groups. The factor favoring the decreased saliva production or stasis, that is by the dehydration, use of the anticholinergics or the diuretics, irregularities in the duct system, local inflammation, and the changes in the second group is the second in the saliva composition, that is the calcium saturation deficit of the crystallization inhibitors such as the phytate, and similarly the bacterial infection also promote the sialolith formation due to an associated increase in the salivary pH favoring the calcium phosphate supersaturation. The hydroxyapatite is the most common mineral found in the sialolith. Epidemiology. The sialolithiasis is most common in the males. The sialoliths occur more commonly in the submandibular gland, that is followed by the parotid gland and then the sublingual glands. The higher rate of the sialolith formation in the submandibular gland are due to the torus course of the Wharton's duct, the higher calcium and the phosphate level of the secretion contained within, the dependent position of the submandibular glands, which leaves them prone to the stasis. Similarly increased mucoid nature of the secretion. Now talking about the clinical manifestation. The clinical manifestation, the pain is acute colicky, periprandial pain, and intermittent swelling of the affected gland. Similarly, typically the salivary gland swelling will be evident upon eating, since the stone completely or partially blocks the flow of the saliva, resulting in the salivary pooling within the ductal system. Where there is a partial obstruction, swelling will subside when the salivary stimulation ceases and the outcome decreases. Often there is a history of sudden onset of the swelling and the pain. The involved gland is often enlarged and there is tender to the palpation. Now, the salivary gland stasis may lead to the infection, FIA, that is fibrosis, infection, and the gland atrophy, FIA. Similarly, the fistula, sinus tract, and the ulceration may also be developed in the tissue overlying the stone. The other complication includes the acute sialadenitis, ductal strictures, and the ductal dilations. Now similarly the investigation, the imaging is done. Okay, the image includes the plain image. It is inexpensive, readily available, and has the minimal radiographic exposure. However, the small and the poorly calcified stones may not be readily visualized. The second is the computed tomography CT. This is the method of the choice when it is readily available. It is capable of detecting the very small and the semi-calcified calculi, but the associated with the high radiation exposure. Similarly, the CBCT, that is the cone beam computed tomography, it has to detect the sialoliths. It can also provide the accurate information on the stone. Accurate information on the stone size and the position as well. Relatively, it is inexpensive and the limited radiation exposure than the CT. Okay, now the next is the ultrasonography, and similarly the sialography is also one of the method. And sialendoscopy can be employed for the direct visualization and often simultaneous treatment of the sialoliths of the parotid and the submandibular glands. The mobile and the small stone can be relatively easily removed, whereas the larger stone may require the prior fragmentation. Now, management of the sialolithiasis. During the acute phase of the sialolithiasis, the initial therapy is primarily supportive. The standard treatment often includes the analgesics for the pain management, hydration, as the etiology has the dehydration, antibiotics if infection is there, antipyretics as indicated. Now, sialogous massage and the heat application to the affected area may also be beneficial. The smaller stone at the near the ductal orifice can be removed transorally by milking of the gland, but the deeper and the larger stones may require the sialadenoscopy or the surgical intervention.